Okay, good morning. I want to welcome all of you to the College of Ag and Human Sciences Research Seminar Series. It's my pleasure to introduce to you today our speaker for today's seminar, Dr. Janet Antwi. Dr. Antwi is an assistant professor in the Human Nutrition and Foods area in the College of Agriculture and Human Sciences here at Prairie A&M University. She is a registered dietitian, and other expertise of Dr. Antwi are public health. She's a public health professional. She's also a registered pharmacist and HIV/AIDS medicines adherence counselor. She has a passion for teaching and undertakes research in both community and clinical settings. She has worked nationally and internationally for the past 9 years in practice and research with hard-to-reach populations and underprivileged communities, and involves her students in community engagement activities. Her research interests include nutrition, education, and interventions for obesity, type 2 diabetes in low-income and underserved populations, an impact of dietary supplements and antioxidant compounds on HIV disease progression. She has published research articles on cardiometabolic risks, inflammation, and vitamin D effect on type 2 diabetes in minorities, college students, nutrition knowledge and perception of type 2 diabetes risk, and lifestyle behaviors and self-related health. Janet holds a bachelor's in pharmacy from Kwame Nkrumah University of Science and Technology, Kumasi, which happens to be my alma mater. She has a master's in international healthcare management, economics, and policy from SDA Bocconi School of Management in Milan, Italy, and a doctor of philosophy in nutrition and dietetics from Florida International University in Miami, Florida. She joined us this year, I believe, in January from State University of New York, Oneonta. Please help me welcome Dr. Antwi as she talks about nutrition education, intervention impact on nutrition, knowledge and practices, and nutrition studies, the NCP model for research in Ghana.
Thank you, Dr. Adam. Good morning, everyone. Okay, so this is a research collaboration that I undertook with some faculty members at the University of Ghana, Legon. So that is in Ghana. And what I have today to share with you is, the current results or the preliminary results that we have. So data analysis is still ongoing. So I'm going to share with you what I have so far. So as we go through the research, I'm going to explain to you what the nutrition care process model is and bring you up to speed about the state of dietetics practice and also the NCP. When I say NCP, it's nutrition care process. So NCP model used in Ghana. I'm going to also talk about nutrition education and also nutrition status among school-age children in Ghana. Then also we'll look at what nutrition intervention was carried out. Okay, so the training of graduate students as research assistants, formative research that was done, intervention, delivery, findings, and interpretation. Then what were the lessons that we learned, and also what is the future research that we are looking at. So this is the NCP model. As you can see here, all right, it is a well-established. So when we say well-established, it means that anywhere that you go in the United States, dietitians use the NCP model, all right? And we say that it's a standardized process because you go through a systematic process that is one step to the next step to the next step. So it constitutes 4 steps. So that is why we say it's a standardized process. And also the reason why we say it's a standardized process is because anywhere that you go in the world is the same steps that you are going to follow. So we have the first step, which is the nutrition assessment. Okay. So over here under nutrition assessment, what is usually done is that you just take data or you collect appropriate or relevant data considering the population that you are looking at. And this data, we have 5 main domains. So we have the anthropometrics, where you take the BMI, you take the height, you take the weight, you take body composition, fat mass, fat-free mass, etc. Then we have biochemical data, where you are trying to look at what are some of the lab results. So what is the glucose level of this patient? What is the sodium levels? What is the hemoglobin levels? Maybe they are having anemia, etc. Then we have the client history. So client history has to do with collecting data on age, gender, marital status, medical history, etc. Then we have the D part, that is the D domain, which is dietary intake. So in dietary intake, you want to see what is the nutrient intake of this population or this individual. You also want to see what is their knowledge, attitude, beliefs about food intake, and also you want to see what are some of the alternative, sources of nutrients that they are taking. So that is the D part. Then we have what we call the nutrition-focused physical finding. So here, for that one, what you do is that you try to do physical examination. So you try to touch them, to see whether are there any sunken parts, especially around their neck area. Are there any sunken parts in their temporalis? Are there any sunken part under their eyes? Are there any sores in their mouth? Is there anything happening in their eyes? Just because you want to detect nutrient deficiency. So that is what is done over there. Then after you've collected all this data, you try to compare it to standards. So that is what we call comparative standards, to see that, for example, if you had a BMI, a person having a BMI of 30, you want to compare to the standard that maybe, is it normal? It's supposed to be 18.5 to 24.5. So BMI of 30 is not normal, is obese. Okay, so that is what is done in a nutrition assessment. Then the second step is nutrition diagnosis over here. So over there, what we do is that we use all the data that we've collected to diagnose the problem that the person is having. And by diagnosing, you look at the P, which is the problem. Then you look at the E. E is etiology. So what is a causative factor? What is the contributing risk factor to the problem? Then we look at the S part, which is the signs and symptoms. So in diagnosing, we put down what we call a PES statement. Then the S means that what are the signs and symptoms? What is the evidence that the problem exists? So that is for the nutrition diagnosis. So you label the problem under nutrition diagnosis, then you try to find how can I solve this problem. So this is where you go to the third step, that is nutrition intervention. So under nutrition intervention, you put down or you plan your intervention, you put down goals. What are the goals that I want to achieve for this population? So if the person has, for example, a BMI of 30, you want to put out a goal that maybe in a month they should lose about 4 pounds of weight. So that is your goal. So over there also we have 4 domains. The first one is you try to do an intervention giving the person food and nutrient delivery if the problem has to do with intake. Then you can also do nutrition counseling or nutrition education if the problem has to do with food and nutrition knowledge deficit. Then you can also do coordination of care. That is, if the problem is beyond nutrition. So, for example, people with eating disorders, their problem is beyond nutrition. They have psychological problems. So it means you have to bring the psychologist in, you have to bring the nurse in, you have to bring in the social worker. So that is the intervention area. So you plan it, and after planning, you have to implement. Because if you plan and you don't implement, it means that how do you know that the intervention is working? Then the fourth step is nutrition monitoring and evaluation over here. So here, as the name goes, monitoring, you are trying to monitor, is my intervention working? All right, so if it is not working, what do I do to make it work? Then we have the evaluation. Compare it to the goal that you set. That at the end of the day, is it, affecting the goal? Is the person losing weight or not? So that is the 4 steps. So not to waste time, I will just quickly go through. Over here at the circles, so the 2 circles are just, other factors that support the model. So it means if you are using the nutrition care process model as a dietitian, you should have dietetics knowledge. You should have competence. So that is the circles that is, surrounding it. So the model was developed in 2003 by the Academy of Nutrition and Dietetics here in the United States. And it was developed to address nutrition-related problems by providing safe, effective, and high-quality nutrition care. And it can be used in the clinical settings, it can be used in the community settings, it can be used in research. So that is why we decided to apply to research. And it's beneficial or it's very useful because it allows comparable data recording process. Because as I mentioned, you have to go through the 4 steps. So there's no way you can jump to step 4 before going to step 2. So you have to go through those, standardized steps. Then it also uses a set of common terms that is called standardized language. And so because of that, you are able to use it on a global platform or for global collaboration because you can, because of those common terms, wherever you are in the world, is the same term. So whether you are using it in Ghana, in Canada, in Brazil, wherever you are, it's the same terms that you have to use. So for example, if it's obesity here, it's obesity in Ghana. If excessive energy intake here is excessive energy intake in Canada, wherever you are, is the same thing. So we are able to collaborate because of that understanding that we get from the terms that is going to be used. So outside the United States, other areas or other countries that are currently using it holistically is Australia, Sweden, Canada, United Kingdom, New Zealand, Malaysia, Spain, just to mention a few. So it means other countries are also using it. So what is the state of nutrition and dietetics and the use of the NCP model in Ghana? In Ghana, currently, there's a lack of dietitians. So we have about 102 dietitians to 25 million Ghanaians. So you can imagine how many people are seeing dietitians in Ghana. And moreover, most of these dietitians are based in the southern part of Ghana. But the NCP model was launched in 2013, that is 10 years after it was introduced here in the United States. So it was launched in October 2013 in Ghana. And in the first workshop, lo and behold, it was also, at the University of Ghana where I did the collaboration with them. And after 3 years, when it was launched, a survey was conducted in 2016 to see that what is the progress or what is how is the model doing. It was realized that there was inadequate implementation of the model in the education system and also in clinical setting, community setting, and its benefits in research was yet to be tapped. So it means it was not, adequately used or was not well used. Another issue with the Ghana dietetics is that there's only a local and country dietetics association. They don't have, a big annual conference like over here in the United States where you have the Food and Nutrition Conference and Expo where a lot of expertise in nutrition and dietetics meet together to talk about brainstorm about education, brainstorm about research, brainstorm about innovative ideas to carry out or to advance the profession. So there's a need to enrich dietetics practice to move the profession and also research in Ghana towards a global platform. And this can be done through building capacity of the workforce through training, mentoring, supervision, support to practice and document according to the NCP model through the enhancement of knowledge and skills. So based on this background or based on this knowledge, what we did was to apply for a grant with the Institute of International Education for collaborative training and research project with the University of Ghana. So that was to build a capacity and global competence, among faculty, especially young faculty, graduate students through training, mentoring, and support through the implementation of the nutrition care process model in collaborative research in Ghana. So we had two parts, that is the training part and the research part. So with that training part, what we did was that we trained 19 graduate students to serve as research assistants and the 2 young faculty members who collaborated with me. It was a 3-day training workshop which involved, PowerPoint presentations because we wanted to explain what the NCP model is, how it can be used, what are the steps that are involved. We also had case studies, discussions, and activities because we want them to have a hands-on, approach sort of thing. Practice, they had role plays. We also had peer review of the study materials so that they'll be conversant with it so that as they apply to research, they'll be able to know how to use it. Then we also had a question and answer session of how to use the NCP model in community settings in research. So after the training, then we had the hands-on, the practical aspect. So this is where we wanted them to apply their knowledge and skills on the field. So it was through an applied experiential learning of primary research where we conducted a pilot study. And with a pilot study, it's the same thing, applying the NCP model to the research. So we implemented a culturally sensitive and age-specific nutrition education intervention among school-age children by comparing the effect of nutrition education on nutrition knowledge, attitude, and practices, and nutrition status between intervention and control groups. We also assess the short-term effect of the nutrition education on the knowledge of caregivers as well as physical education teachers of the school children. This included both qualitative and quantitative, components, but because of time, I've just saved the qualitative. I'm going to talk only about the qualitative. So why did we use school-age children in Ghana? We use school-age children in Ghana because a double burden of malnutrition has been observed among, this population, where you have undernutrition with micronutrient deficiencies, especially vitamin A and iron, coexisting with obesity. Just because, the developing countries are also catching up with the westernization, where you have high fatty foods, high sugar sweetened foods around. So we are also seeing this in developing countries. And currently in Ghana, there's no nationwide data, nutrition education as well as nutrition status of children, school-age children. But the few studies that have been done shows that there are about 52.2% of school-age children who are stunted, 46.5% are underweight, 17% are overweight and obese. And school-age children are particularly vulnerable to malnutrition because of the fact that most of the nutrition research and interventions that are ongoing target mostly those children below 5 years or at 5 years. Even in the United States, we realize that they give more importance to children at 5 years and below 5 years. And because malnutrition is linked with poor cognitive function, intelligent quotient, poor school attendance, and low school achievement, and since these people or these children are in school, it means that we have to make sure that we address the problem. So what is the current nutrition effort that has been done among school-age children? In 2003, the Ministry of Education and Ministry of Health launched the school feeding program where school-age children are given one pot meal per day when they are in school. And in 2003, it reached only 4% of the population. By 2016, that is how many? 13 years after, only 30% of the school-age children have been reached. So another issue is that the efforts, these efforts do not underscore the provision of nutrition knowledge and skills, which is very important when you want the child to attain, the knowledge or the nutrition enhancing behaviors to be able to adopt it to improve their nutrition status. There's also deficits in the current primary school curriculum because we don't have coverage of nutrition education courses in the curriculum. And this implies that nutrition knowledge, attitude, and practices could be lacking or it need improvement among school-age children. And school-age children, we targeted them because they are an appropriate age, apart from the fact that they are vulnerable, they are an appropriate age also because they are the critical age where you can, help them to form good dietary habits. So our hypothesis, we hypothesize that nutrition education will increase the level of nutrition knowledge, attitude, and practices in its intervention groups compared to control groups among school-age children. And for the teachers and caregivers, we also said that it would increase their nutrition-related knowledge. For our outcomes, our primary outcome was nutrition knowledge, attitude, and practices, and our secondary outcome was nutrition status, which is improved stuntedness, improvement in wastedness, and also improvement in underweight. So our study design and area, we use a pre-post controlled design. So it means that before, then after, we took, data collection. And this was conducted between September and December of 2018. IRB was obtained from the University of Ghana, and permission was also obtained from the Ghana Education Service. We used 2 urban areas. The urban areas were located in the capital city, which is Accra, then 2 rural areas, which is located in the eastern region of Ghana. So for study population, we sampled school-age children between the ages of 6 to 12 years in classes 1 to 6. They are primary caregivers, especially for those in the intervention schools. They are PE teachers, again, in the intervention schools. And they were conveniently selected. So it wasn't like we had any special thing. We just conveniently selected them and randomized them. So we randomized to, control groups and intervention schools, rural and urban. So there were a total of 325, 99, and 6 school-age children, caregivers, and PE teachers, respectively. And we used different recruitment methods. For one school, we're able to use a parent-teacher association meeting. And so we explained the research, we explained the risks involved, we explained everything to the parents, then they give us their consent. But for other schools, because of conflicting times, we could not do that. So what we just did was that we gave approval letters to the children. They took it home, then they brought the approval and the consent back. So in going through the nutrition care process, for step 1 under data collection, we collected data on client history, so the age, the gender, the income, the residence, household size, etc. And for nutrition knowledge, attitude, and practice information, what we did was that we used a validator questionnaire to collect data about the nutrition knowledge of the children. And this focused on 5 areas. That is food, nutrient, and function, food choices, nutrient deficiency, sources of nutrients, and food and energy. And the specific questions differed between the upper level and the lower level primary. So for lower level primary, which is class 1 to 3, they had a different set of knowledge questions because we wanted to meet these levels at the level of their intellect. We didn't want to have the upper level doing the same questions as the lower level. Then for attitude and practice questions, it focused on 4 areas, which is food intake, diet quality, food choices, and food and health. For our dietary intake, we use a 24-hour recall method. The 24-hour recall method, what it does is that you ask the client or you ask the individual what they've eaten over the past 24 hours. So they are able to recall it. And you also ask detailed questions about the time that they ate it, what is the amount that they ate, what are the sources, was it home cooked or they bought it, was it a brand? You ask them all those questions. And in helping the children to recollect, what we did was that we gave them food models so that they'll be able to remember the portion sizes. So this information was used to calculate the dietary diversity score. The dietary diversity score is a proxy of diet quality or nutrient adequacy. So in a country like Ghana or in Africa where most of our staple food comes from starch, you want to make sure that the child's diet is varied or whatever thing that the person is taking in is varied from all the food groups. So it's able to help us to know whether are there any micronutrient intake or not. So we use the FAO guidelines where we just have a list of the group of food groups. Then we check, if the person took it in or not. We check it, and for a score of 4 or below, that is a low dietary diversity score. For a score of 5 and above, that is adequate or enough dietary diversity score. Then for anthropometrics, we use the height. We measured height by making sure that there were no shoes on to the nearest 0.1 centimeters using a stadiometer. Then we use also a scale to measure weight to the nearest 0.1 kilogram. So this is the nutrition diagnosis. As you can see, all right, this is the key part that I was talking about. So this is the problem. That is food and nutrition related knowledge deficit. So after collecting all the data that we needed to collect, this is the problem that we identified. And related to. So related to means that what is a causative factor or what is a contributing risk factor? And we realized that because of limited prior formal school HR nutrition related education, all right? So they do not have nutrition related education. And how did we know? What was the evidence? The evidence was the fact that after administering those questionnaires, more than 75% of them had incorrect responses to questions regarding their nutrition, recommendation, the 7 sizes of food, the physiological functions of nutrients. They were unable to identify food sources of nutrients and name some foods that belong to groups of food groups such as grains, protein, and dairy groups. So that is how we were able to know. So what did we do? So after identifying that the intervention has to target the etiology, which is here inadequate, formal nutrition education. So we decided to implement nutrition education amongst them. And this was based on the social cognitive theory framework. This framework holds that learning or parts of an individual's knowledge acquisition is based on the social context. So interaction with their personal characteristics, behavioral patterns, and also environmental factors that has to do with their food environment. So for PE teachers, we gave them a 3-day nutrition education workshop as well to be able to help them increase their nutrition knowledge and also to be able to help them have the self-efficacy that when we go away, they will be able to adopt the nutrition education and teach it confidently to their students. Then caregivers were also taken through a 1-day nutrition education. So this was also to help caregivers to implement it at home. Then for children, we gave them 6 weeks nutrition education, which was incorporated into the PE lessons. So the intervention included 6 nutrition topics. That was on food groups, functions of food, food choices, breakfast and snacks, portion and serving sizes, physical activity and food safety, and personal hygiene. And this was, as I mentioned, taught for an hour each week for 6 weeks during the physical education class. So we know very well that children have a short attention span. So in order to keep them interested, to make it fun for them, we included small group discussions, hands-on activities such as building a healthy plate, workbook assignments, singing sessions, and even nutrition contests. Then the control group received only the standard PE curriculum, which is during PE, what they do is that they just go out and do physical fitness playing on the field. So step 4, our nutrition monitoring and evaluation. We consistently visited the intervention schools over the 6-week intervention period. One, we wanted to ensure that implementation was being effectively done and also to answer any questions that or concerns that the teachers might have. So to evaluate for teachers and caregivers, their evaluation took place right after we did the nutrition education workshop for them. So before and soon after. So after the 3 days, we did the posts, data collection for the teachers. Then right after that day, that's 1 day for the caregivers, we did the data collection. But for the children, we did the post intervention data collection after 6 weeks. So our statistical analysis, our primary outcome, as I already mentioned, is nutrition knowledge, attitude, and practices. The nutrition status was our secondary outcome. So PET test was employed to see what is the differences, within an individual, that is pre and post test with their nutrition knowledge, attitude, and dietary diversity scores. Then we use independent t-test and chi-square test for group mean differences, so between the intervention and control. So SPSS version 20 was used for data analysis, and a p-value of less than 0.05 was considered statistically significant. So this is the results. It's hard to see, but just bear with me. So we have here, as you can see, with the p-values, you realize that with the exception of ethnicity, okay, which differed, all the baseline characteristics or baseline variables were similar between the intervention and control group. And for age, the mean age was 9.6 years, and about 70% of them were between the ages of 9 to 12 years. So that is the upper primary level students. Then for source that provided the most nutrition information to school-age children, as you can see, family members played a very, very huge role over here, where most of the children answered that is the family members that provided them with most of the nutrition information. So intervention, schools, more than 50% of them said that, and for the control schools, 43.9% with a p-value of less than of 0.01. Then we have the second the source of information is lessons taught in school, which was at par with the results. Then for the source of information that the children like most, the same thing, family members played a huge role. So they like the information, or they like to have information from their family members, and that was also more than 50%, 46.3%. The second, which was also statistically significant. Then the second one is lessons taught in class, which was 27.9% in intervention and 19.5% in control schools. So this is the nutrition knowledge results. So here, as you can see, for the lower primary class, that is class 1 to 3, and this is the upper primary class, that is class 4 to 6, you realize that within the intervention groups for both upper primary and lower primary, there was an increase in knowledge, all right? So that was statistically significant, okay? But when you look at comparing between the intervention and control groups, you realize that it was only significant for the lower primary. The upper primary did not significantly increase the nutrition comparing intervention and control groups. So for nutrition attitude, a higher proportion of children in intervention groups said that they enjoy learning about food and nutrition issues. That was 88% versus 77%, with a p-value of 0.03. On the other hand, a significantly higher proportion of children in the control group believed that eating healthy foods was only important during illness. So it means that they only attributed healthy eating for illness. So that one also 81% for the intervention schools, then 68% for the control groups with a p-value of 0.02. Then for nutrition practices, so this one was something that was very contrary to what we were expecting. in the sense that we're expecting that because of the nutrition education that we had given the children for the intervention schools or intervention group, they were going to increase in their dietary diversity score. So before the intervention, as you can see here, all right, the intervention group had a higher dietary diversity score. It means that their diet varied compared to the control group, which was significant. But after the intervention, interestingly or surprisingly, the intervention group had their dietary diversity score dropping, and the control group had their dietary diversity score increasing, right? So that was very strange to us. And as you can see, both differences or both changes were statistically significant. But if you compare it between the intervention and the control group, the difference was not significant. It's within that was significant. But when you compare it across or between, it was not significant. So for nutrition status, which was our secondary outcome, there was no significant differences that was observed between the two study groups in terms of any of the anthropometric indicators that we assessed. However, there was a tendency for the intervention group to have a lower proportion of stunted children compared to the control group at the end of the study. So you have 3.6% for the control group, for the intervention group, and 8.2% for the control group. But this one was also not, it was marginal. It was getting there to be statistically significant. So in order to understand the discussion or interpretation of the results, I want to show you a little results from from the teachers and also from the caregivers. So for nutrition knowledge for teachers, you realize that after the intervention, all right, the teachers significantly increased or improved their nutrition knowledge from 9.2 to 12.5, p-value of 0.031. And when we asked them also about their self-efficacy, they all said that they felt confident that they could teach nutrition education to their students. So it means there was an improvement with teachers. However, when it comes to the caregivers, we realized that the rural area caregivers significantly increased or improved their nutrition knowledge, but the urban caregivers did not. All right, so that was not significantly different before and after the intervention. But overall, there was significant difference in nutrition knowledge before and after, just because the fact that the rural areas contributed to that. So that was very interesting. Then we have also another thing that we observe about food security, that most of the caregivers in our population were food insecure, with or without hunger. And this was very much pronounced, high prevalence among caregivers in the rural area. So when you look at this one, you realize that caregivers in the urban area, about 53.3% of them were food secure. Then you have being food insecure without hunger and food insecure with hunger. Then when you look at here, you realize that half of the rural caregivers were food insecure with hunger, followed by without hunger. So overall, both being a food secure and food insecure were like at the same level in our population, which we realized was a very, very important issue that could have affected our results. So in the discussion, the first observation that we made, or the first thing that we saw, was that the significant improvements in the nutrition knowledge, all right, especially with the lower level and with the rural area caregivers, did not lead to general improvements in nutrition practices, as you can see in the dietary diversity score that I showed you. And the reason that we came up with was because maybe the upper primary school children, who form majority of the child participants, did not significantly improve their nutrition knowledge, which was coupled with a higher proportion of caregivers in our sample in the urban areas also who did not improve their nutrition knowledge. And research has shown that one of the major determinants of dietary practices that can be adopted among children is the nutrition knowledge of their caregivers. Also, low levels of nutrition education have consistently been found among women with poor nutrition practices and malnourished children. And our third reason was because of the general high prevalence of food insecurity, as I showed you, with or without hunger among caregivers. That means that I have the knowledge, but I don't have access to the food that you are telling me to eat to make my diet varied, so it did not translate into practice. So research has also shown that in children, food consumption is associated with foods that are available and accessible at homes. And also, despite adequate nutrition awareness and knowledge, you can have all the positive attitude. But if there's lack of food availability and accessibility, it means that it cannot help an individual to achieve a healthy and varied diet, and especially when it's in low socioeconomic households. So the second thing that we found out was also about the nutrition status, that there was a marginal trend with a p-value of 0.08 that we saw over there, that the intervention group had a lower level of standardness compared to the control group, right? And the reason why it was, we are saying that it was not statistically significant was maybe because of the fact that since they did not improve in their nutrition practices, it means they were not able to, also have enough or adequate food intake to be able to grow well. And one thing also that has been shown in research is that children's good nutrition practices and dietary intake provide the dietary as well as the nutrients that are essential for growth and development. And another reason that we also put out there was maybe because of the duration of our intervention, which was only 6 weeks. Because those interventions that saw an improvement in nutrition status, that is, an improvement in stunted,ness, an improvement in underweight, an improvement in wasting, they were carried out for a longer period of time, between 3 to 5 years. But we did ours for only 6 weeks. Another reason that we came up with also based on literature is because during this period, especially when they are 5 to 11 years, their growth rate, slows down compared to when they are below 5 years. So we also had in our sample about 80% of the school age children fall in between this age range. So that could have caused us not to see any significant improvement in the weight and in the high status. Strengths and limitations for implemented, all right, in Ghana. In research. Let me correct myself, in research. And the research assistants were able to use all the steps that were involved throughout the research process. And we also involved caregivers and teachers, all right, just because we wanted to empower them to be able to, implement it at home, and also for the teachers to be able to have the self-efficacy to teach the nutrition education to the children in the long term as part of the curriculum. We also, one other strength is that this has contributed to the limited data that is available for nutrition knowledge, attitude and practices, and nutrition status. One limitation is we saw as a weakness is the fact that we did not use the same, recruitment techniques for the 4 schools. So we used some PTA, then we used some newsletters. Then also the use of self-reported 24-hour, because we are asking the children to recall, sometimes memory can fail us. So there could be overestimation or underestimation of, the actual dietary intakes. And also variation in teaching styles. These teachers that we train, yes, we train them, but they have different styles through which they teach. So that could also have affected, the way that children learn. And also the caregivers, that could also be an influence with teaching styles. Then different exposures. So differences in exposure to nutrition information. Remember where we saw the family being an important role when it comes to nutrition information in school age children. So if the mother is not improving their nutrition knowledge, you can imagine what is going to happen. So that could also have affected the children's responses to our nutrition education intervention. And due to time, financial, and human resource constraints, we couldn't, extend the training period for the teachers. It was only 2 days, and for the caregivers, it was just a day. People can, sometimes people cannot just get that knowledge within a day. So that could also have been an issue. And we did not involve school cooks, food vendors, who can also influence the food environment in the school. And we did not also obtain household and educational level of caregivers who were in the control group. We did not have that information available. So what are the lessons learned? The lesson that we learned was that improving the nutrition knowledge, attitude, and practices of all relevant stakeholders. So this is where you involve everybody, the family, the teachers, even the government, the school cooks, the vendors, etc., in addition to improving the food environment that they find themselves in. So the school environment as well as the food environment at home is very, very crucial for improved nutrition status. And one thing also is because of the fact that when you are educating people, all right, about the importance of healthy diets, it may be an insufficient approach just because they have other factors that are playing a role, which is economic factors, environmental factors. So even though you are giving them the knowledge, if they don't have that availability, accessibility, it means that they cannot practice what we are teaching them. So in our next step, what we plan to do is to address both that while we are addressing the nutrition education knowledge deficit, we also want to address the food environment to make sure that maybe we are engaging the caregivers in, farming. Farming is one of the huge occupations in the rural areas, so engaging them in farming that has to do with animal or crop, So we engage them in that so that they will have produce available to be able to practice, what we are doing. So that is the next step that we want to look at it, especially when people are disadvantaged or have food insecurity. So these are the references, a few of them, all of them. Right. So thank you. Any questions?
I want to thank Dr. Antwi for that interesting presentation. It's not just the children. I have a hard time recalling what happened 24 hours, even though I remember things that happened, years ago. So, but thank you for that interesting presentation. I have a question. You talked about how the knowledge of the caregivers in the rural areas, improved compared to those in urban. What you think is the reason why?
It could be that the rural area caregivers did not have much exposure compared to those in the urban areas. Maybe they had already had a previous exposure to some form of nutrition knowledge, so even adding all what we had did not significantly make any changes or any difference. Compared to the rural areas where they usually have a lack of access to information. So that could have maybe, because they were more interested, they were more involved, they wanted to learn something, so that could have maybe caused the increase. It could also be that we actually had different people doing the education for the rural areas and the urban areas. So it could be the teaching style of those who did the education. Although we trained them, I mean, that could also have influence in that they did not deliver as they were supposed to deliver, and so that could have maybe caused them differences.
Good. Okay, are there any questions?
So, in traveling through most of Africa, wherever I go, I consistently see this issue. We're talking about availability of food in general, right? And so, socioeconomic status of people, poverty, and many other factors, of course. But you can tell that people are struggling to get 1 meal a day in many places, right? And so staple food has become the norm of anything and everything, that you eat. If a place is known to eat rice, they eat rice every day, every time. If it's beans, it's beans. If it's maize, or maize flour, which is very common, right? So I guess those are limiting issues when it comes to studies like these and trying to implement nutritional awareness, so to speak. I wonder what your experiences are. Thank you.
Okay, so as I rightly presented, it can be a deterrent. It can be a barrier in the sense that yes, the people will improve their knowledge, they will increase their awareness, but just because of the fact that they have this, limitation, it will not translate into practice. For most of the cases, you wouldn't see them, changing their habits because it's not available. I can't have access to it. So how do I change my practice? It's what I have that I eat. So that is what you see in most of these places. So that is why it's very important for us to change the environment, to improve the environment, so that as you are increasing, when there's abundance, when there's availability, and you give the knowledge, they'll be able to know that, okay, this is the relationship between the food I eat and my nutrition status, between my weight, between my health, even my health. So that can help them to be able to practice what you teach.
Thank you so much for sharing. I just wanted to comment on you said you gave food models to the children to help them learn. We have a program very similar, our FNEP, Expanded Food Nutrition Education Program. And we train the parents and the children. Most of the children are trained mostly at school. But when we do the 24-hour food recall, but we also, when we're teaching a lesson, we have the foods for the recipe because we always have taste testing. And then we give as a door prize or whatever, we might give the ingredients to that recipe for them to take home and try. So just future, yes, things that might help enhance that learning. But again, if the food is an insecure issue there, that could be another problem. But we do give the recipe for them to take home, the ingredients to try.
Thank you for sharing too.
I do see a number of our students in here. Thank you all for coming. But you all have any question for Dr. Antwi? Put you on the spot, right? Okay.
They are afraid I will give them a low grade if they ask questions.
Okay, any other questions, please?
If there's no questions, a couple of announcements. And so today is an auspicious day. And the reason why it's auspicious is because it's the launch of the farmers market here on campus. It's been talked about for many years, and we finally are reaching reality thanks to the students, many of whom are around here, and the faculty and staff of the college. So if you get a chance, stop by the bistro this morning. It goes on from 9 till 1, and we're trying to do this every Thursday, possibly on Saturday as well. And it's a partnership between the university, and specifically the College of Ag and Human Sciences, and the Prairie community. Some of the small farmers in the area also have an opportunity to sell their food at this farmers market on campus at the bistro. So what a perfect start to the day. You know, we had this great talk about nutrition and food deserts and so on. And here we are actually trying to do something about addressing the food desert, which is what we have in Prairie. So this should resonate with the students as well because it is student-led, student-run. We've got a student-led garden, vegetable garden on the farm, and students have been working hard all summer to get the produce ready for market. And so the launch of the farmers market today, so go there and support them. The other announcement is we have two special guests in the audience from College Station, Texas A&M, and they're from the Department of Agricultural Leadership, Education, and Communications. So Dr. Matt Baker, sitting back there, is the department head. Dr. Gary Wingenbach is a professor in that department. And he and I were colleagues at another institution up north some 20 years ago. We both started out as assistant professors. He's managed to retain a lot more of his hair than I have. But regardless, it's great to reunite here after many years. So again, they are at College Station. It is a well-known department, number 2 in the country in the area. They have a lot of great education programs, undergraduate, master's, and Ph.D. So the reason they're here is we're trying to collaborate with them in terms of the 3 mission areas, teaching, research, extension, and also in the area of international education. And Dr. Wingenbach in particular is associated with the Borlaug Institute, which many of you have heard about on the campus of Texas A&M. Norman Borlaug, after whom this institute is named, went on to win the Nobel Prize in Peace, 1970. The reason was because of his contribution to addressing food insecurity through the Green Revolution in India and Mexico and so on. So his work continues through the Institute And so we're trying to partner with them to figure out how the Food Security Center here on campus, a Chancellor Research Initiative, and I was hoping Dr. Elaine Myers would be here, but he's not. He's leading that center. How can we partner with the Borlaug Institute and do some great things to address hunger in this part of the world? So we've got a lot of great plans ahead. Dr. Ray and Ashley back there working with them on different areas. And so we hope to broaden this partnership. So if you get an opportunity, stop by, say hello. And we're going to go take them to the farmers market after this and show them around, show them the campus. So just a couple of quick announcements. Thanks.
Okay. Any other questions?
Hello. Actually, I did have a question in terms of to expand upon the comments about rice, if all you have is rice or beans or whatever. I too have seen the same thing, and I'm curious if any thought was given to or could be in the future, not so much in the change of staple foods, because sometimes all you have is what you have, but in the preparation or the processing of them. For example, many places I've gone, the vegetables are boiled until there's absolutely nothing left in the vegetable, and the water is thrown out, which kind of defeats the whole purpose of the macronutrients and minerals. Have you seen any of that, or is that a consideration in terms of retaining some of the food's properties?
Actually, that's exactly what happens in Ghana. We cook and fry and fry and fry and fry. So there's nothing yet in the food. And when we are boiling vegetables, add a whole lot of water, boil. Then, as you said, discard the water. So maybe, as you said, moving forward, another thing that we can adopt is to teach them these cooking methods that can retain some of the nutrients using little water. Instead of using high heat, maybe low heat, and if you use a lot of water, just use the water to prepare your soup or your stew. So we are going to see how to adopt some of these cooking methods to be able to help them retain some of the nutrients. That's a good suggestion.
Okay. If there are no other questions or comments, let's give Dr. Antwi another round of applause. And do we have the announcement for next week's seminar series? Okay, so we have a speaker. We don't have the topic yet. Okay. Okay. Sure.
It's going to be an interesting topic. It's about hemp, and I think we're moving in that direction in the college, but this is a